Good afternoon, everyone. My name is Noluthando Ndlovu, and I'm a program manager at the Health Systems Trust, but I'm also part of the Salad Collective. We'd just like to thank you for giving up 90 minutes of your day today to have this important discussion where we will be looking at reorienting the DHS towards health promotion and wellness. So, yeah, as we know, South Africa's DHS still leans heavily toward a very curative and vertical programs, yet the burden of disease now is really demanding us to shift to health promotion and wellness. And this really includes prevention, early intervention, and people-centered care. In our webinar today, we'll be focusing on the how with our wonderful panel who will be sharing some of their interventions with us, but also some of the strategic work that's been done towards achieving this. So, in terms of the session today, it will be run in two sessions. In the first segment, we're going to have quite a nice rapid fire panel of interventions and then have some of your audience reflections. So, please do pop in your comments and questions in the chat box. Then in the second session, I'll hand over to Eleanor and she will then facilitate that section that's going to focus on strategy, a little bit of Q&A, and then we'll be wrapping up and, yeah, discussing next steps. So as I mentioned, please do feel free to pop your questions into the chat. In terms of ground rules, please do keep your microphones muted unless you're speaking. You can keep your cameras on if the bandwidth allows, but please do also engage respectfully. Um, so just to get us thinking, we already have a poll question that we'd like you to reflect on. So please do grab your phone or open another tab on your laptop. There's a link in the chat box that's been shared by Layla. If you click on that, the question that we are asking is, what is one thing that could unlock the potential of the DHS to better support health promotion and wellness? You're welcome to type in a single word or a short phrase, and then we'll reflect on some of your responses a bit later on. So, to get us started, we're going to start with three practitioners who have really rolled up their sleeves and implemented real world health promotion or wellness initiatives. Just to introduce our three panel speakers, we have Ms. Zoleka Mbange, who is the Deputy Director for Health Promotion in the Eastern Cape Province. Zoleka is really going to just highlight a provincial health communication campaign, which was embedding promotion at ward level. Secondly, we have Ms. Kelly Fortune, who is a Deputy Director in the Western Cape Government, focusing on health and wellness. And again, we're working within the wellness program. And then lastly but not least, we've got Nozipho Madi, who's a community health champion based in KwaZulu-Natal. And she also coordinates Family One home visiting teams, supporting households to adopt healthier outcomes. So each speaker is going to be going through some of these slides, and they have exactly 3 minutes. So please, could you kindly cover the goal, the core design features, and some of your early gains? Over to you, Ms. Mbange.
Thank you for accepting me, Tandy. I greet you all as the audience of this session. As a health promotion practitioner, I want to firstly start with a disclaimer. When I'm doing my slides, I will be focusing mainly on operation. That is, I won't be talking about a strategy at the head office level, but I will be talking about the operations in the community level. First of all, I want to say, as health promotion, we are a team of 69 in the province of the Eastern Cape. That has a population of 7.2. And if you look at the sub-districts, we have 1 to 5 health promotion practitioners per sub-district. We are based in the sub-districts or in the community health care centers or in the clinics. And therefore, what we are doing as health promotion is to ensure that we improve the health and well-being of the individuals, and we empower our communities to make positive health choices and ensure that we create healthy, supportive environments. We know that people are embarking on risky behaviors, which we discourage. And if we talk risky behaviors, we look at usage of tobacco, look usage of alcohol. And again, we've seen the usage of drugs in our areas. Uh, our children are being called damapara, and that's not a good thing to say. We've seen how people are abused in our communities, and therefore we have ensured that in the Eastern Cape we promote physical activity. And not only physical activity, groups that are doing physical activity. Now we are in the winter, people are busy using their imbaulas. We are discouraging the injuries because of fire that causes burns. We've seen how violent people are in our country. We discourage that. And again, we discourage sexual abuse in our community settings. And we are also promoting positive mental health. And if we look at our communities, I'm sure the team from the Eastern Cape will agree with me when health promotion practitioners goes to the transport office are requesting transport to visit the communities because they want to empower the communities. And by so doing that, we are strengthening the primary healthcare approach. And since we are dealing with primary prevention, we want to ensure that we don't go to the second level of prevention, which is secondary. But when the conditions cannot be prevented, we are saying to people, seek medical attention. There are your health facilities. Utilize them. We do community diagnosis in our area so that we know what is happening what disease burden do we have in our areas. We want to ensure that we map our areas, who is in our communities. We also do profiling in our areas. We use surveys to identify the source of diseases, and we ensure that we introduce appropriate services. And we don't only do that by ourselves, we engage the communities. That's why we were able to build relations with our churches, with our community leaders, with our traditional health practitioners, with the civil society, and the rest. And we ensure that we implement these wellness programs in our areas. You'll find that we have elderly that are doing physical activities in their areas, and we support them, we visit them, we promote infection prevention control in our area so that we access clean water. And we not only that, we have dialogues with the communities so that we ensure that we understand them. We want to understand their social behaviors, their behavior trends. And we all not only do that, if you look at the Eastern Cape, the Health Promotion Directorate was the one that initiated the establishment of the health post. We embraced the coming into being of the CCMDD program because now we could see that we will be able to manage our diseases. That's why when you look at our communities and our program, we ensure that we come closer to the communities so that we provide them with skills. And we not only do that, we want to ensure that they do get the information, they have the skills, and we work in our communities so that our communities are able to strengthen their action and work
Mm.
hand in glove with the Department of Health.
Thank you so much, Zoleka. Your initiative sounds like it was quite wonderful. And on screen, we're currently seeing one of the youth physical exercises, yeah, that was done in the Eastern Cape to promote health. Please, could we have our next panelist who will share also on her experience? Miss Kelly Fortune, please come online and tell us about the wonderful work that you've been doing in the Western Cape.
Great, thank you. I just want to share my screen. Just want to check that everybody can see it.
Yes, we can. Please go ahead, and you have 3 minutes.
Just give me a second to put my camera on as well.
Sure.
Okay. I don't know. Okay, let's leave the camera for now. I'll put my face on hopefully afterward. But thank you so much, everybody, and thank you for the opportunity to share a little bit about the Western Cape and Wellness Initiative as a lever for wellness in the Western Cape. I just want to now move my slide. All right, so about WOW. WOW is really about co-creating wellness-enabling environments. It follows a collaborative approach, and it is a lever for increasing wellness by the Western Cape Government Department of Health and Wellness. We focus on the mostly healthy and defined episodes of care. And as you can see on the screen, from WOW's inception, it was really focused on the burden of NCDs and is now evolving to address overall wellness. It supports the health system reorientation, shifting to prevention and promotion from an illness focus in line with COPC, as well as on the journey toward universal health coverage. WOW is a wellness movement that aims to strengthen self-management and empower communities to take control of their own health and well-being. And so at the heartbeat of WOW is our WOW champions. As you can see, a vibrant bunch of community people that are really the spark plug for change. We have over 700 active champions across all districts in the Western Cape province. Champions are self-selected, trained, and lead peer-based wellness groups across multiple settings. So WOW is a behavior change nudge platform. And as you can see by the map, WOW is well dispersed across the Western Cape province. WOW uses behavioral economic principles to nudge healthy habits. It is supported by bi-weekly messages, social cues, peer influence, and group-based routines. Through accessible tools that is shared by the increasing wellness team and community leadership, we are seeing scalable impact. What we are recognizing is that if we meet people where they are, we nudge them gently and celebrate their wins, wellness becomes a way of life. And so in terms of some of the opportunities and sustainability parameters, what we are seeing and where we are going is depicted on the slide on the screen. But importantly, that WOW is making a difference. We are expanding our reach. Partnerships are being strengthened. Improved healthy lifestyles are part of what we're seeing. And of course, shifting wellness norms within our communities. Following a COPC approach, what we can see on the other side of the screen is how we are integrating WOW as a lever for the wellness approach in our facilities as well as in the community, working with the whole of society to increase wellness. On the next slide, we will see how COPC and WOW is put into action. And so as I close off, when we invest in people, we build systems that are sustainable and hold humanity at the center. WOW shows that this is possible through partnership, people-led wellness, and a prevention-first approach. We need to move beyond silos and vertical approaches to strengthen the integrated and comprehensive approaches to health and well-being. Our resource reality enables us to be innovative and maximize our partner and champion networks. The shift from an illness focus to a wellness focus is imperative, where we will embed, and we are embedding, the wellness approach across the whole of society. Scaling up at local level is another key enabler, where we leverage COPC and we train the trainer to cascade the approach. And importantly, that there is commitment to a long-term impact, because measuring soft health outcomes remains complex, and so does behavior change, because it certainly takes time. And so you can help scale up the co-creation of a wellness culture. Join the wellness movement. Thank you so much, everybody. You'll see some slides just again of our amazing champions. There are about 56 pictures, which I won't get through today, but thank you so much for the opportunity to share about the wellness movement, and please do join us, Scale Up.
Thank you so much, Kelly, and for sharing those pictures and the wonderful initiative. It really does sound amazing. I'd like us to now move on to Nozipho Madi. Nozipho, are you there? Nozipho is a community health champion in KwaZulu-Natal, and she coordinates the Family One home visiting teams that are supporting households to adopt healthier routines in KwaZulu-Natal. Nozipho, over to you.
Good afternoon, everyone, and thank you for the opportunity. I hope my mic is you can hear me well.
You please go ahead, and you can switch on your camera if you'd like as well.
I'll prefer to keep it off for now.
That's
So my
perfectly fine.
Okay, thank you. So my presentation is on the implementation of the household champion and family MOAG in brackets mid upper arm circumference intervention at Umzinyathi Health District. So Umzinyathi District has been experiencing ongoing challenges with clients on defaulting on chronic treatment, poor coverage of cervical cancer screening, poor immunization, and a high number of children under the age of 5 years being admitted to the hospital and eventually passing away due to severe acute malnutrition as a result of late identification of at-risk cases. As a response to address these challenges, the district embarked on implementing two community-based interventions with an aim of improving the quality of care and empowering families to take full responsibility of their health and well-being. These are the household champion and family MOAG interventions. The objectives of these two interventions were to capacitate household members on early identification of health-related issues that need medical attention and maintain constant communication with community healthcare workers, thereby shifting the task to the mother and other family members. Secondly, to empower caregivers on appropriate infant feeding choices, recognition of danger signs, and to screen their children using a simple color-coded mid-upper arm circumference tape, and also assessing bilateral pitting edema in order to detect malnutrition early and seek healthcare and support. Thirdly, to provide targeted support to vulnerable groups, including infant and young children, the elderly, pregnant and breastfeeding women, as well as to increase adherence by clients to treatment. The Family MOAG project was introduced and implemented in 2021 in Multisat District. Two facilities were initially identified to implement the project. As a nutritionist, I supervise the implementation and reporting of the intervention at sub-district level and provide mentorship to community healthcare workers at community level. Since implementation of these interventions, there has been some improvement in the number of children admitted as SAM or severe acute malnutrition from these facilities. However, there are challenges that arise, which include community healthcare workers struggling to accurately measure the MOAG according to the SOP, even though they had attended training, and screening using the MOAG tape is an essential part of their daily activities. There are communities without community healthcare workers, often referred to as gray areas, where implementation of these interventions is not possible. As such, there are missed opportunities for early case identification. We also experience resistance from mothers and caregivers. Some struggle to follow the process of using the MOAG tape, and others are unwilling to screen their children completely. So we always encourage our community healthcare workers to conduct several support visits to support these mothers and emphasize the importance of this project. And also regular communication with some of the community healthcare workers to monitor their progress is often affected as some reside in areas with poor connection and are often affected by the lack of electricity. Lastly, continuous in-service support and learning, which is meant to be conducted on a monthly to quarterly basis, is often postponed as many community healthcare workers struggle with transport to the hospital. In the sub-district, we have a total of 15 primary healthcare facilities, excluding our mobile clinics. And as of June 2025, a total of 5 facilities are successfully implementing these interventions. The goal is to have all of our primary healthcare facilities implementing these interventions, as we have seen the impact that they have in our community. Thank you for listening.
Thank you so much, Nozipho. We really appreciate you sharing about the innovative work that you're doing to support health promotion in KZN. So this is now open to the audience. Please do join us now in this discussion. We've just heard 3 diverse approaches, and we'd love to hear your reflections. So please, could you kindly raise your virtual hand? Or unmute yourself. Alternatively, you can also share some of your insights in our chat. And please also do remember the poll that we were doing in the beginning. Please also share there if you haven't already, and then we can also reflect on that. So anybody in the audience who has some insights that they'd like to share with the group, please raise your hand or unmute yourself. Would like to hear some of your thoughts and your reflections, particularly on the 3 that we just heard now, but anything else that you may be doing in your own district or in your own organization to support health promotion and wellness. Mhm. If I can't see your hand, please do just go ahead. Otherwise, I'm going to randomly pick on people. Do more, please. Go ahead. Thank you.
Good afternoon. Am I audible enough?
Yes, we can hear you. Thanks.
Thank you very much. Thank you for the opportunity. I highly appreciate the opportunity for this platform, and the topic that is being discussed this afternoon is a very interesting one. And I can also say it's one of those that are really needed to be further discussed and drive the implementation. However, while listening, I just wanted to understand from the presenters what would be their understanding of the roles and the functions of community health workers and ward-based primary healthcare outreach teams. Thank you.
Would any of our panelists like to take that question? Kelly, Zoleka, Nozipho? Nozipho, I see you unmuted.
Sorry. So from our side, our community healthcare workers are our first point of contact because they are the one who knows the communities very well. And often when we want to introduce a project or we want to host a campaign, since they are familiar with the environment and the community, it is easier to gain access to those particular communities through them because we have found that there's not that much resistance from community members when someone that they know comes to them and speaks in a way that they understand and makes them also comfortable to let other people, I guess, invade their space. So they are our first point of contact. They link us with the community and they are vital in sharing information. That's
Thank
from my
you.
side.
Thanks, Nozipho. I appreciate the response. There's a nice question in the chat that's been posed to the Western Cape team. How has the WHO framework related to the life course approach influenced the way the department organized itself towards a more integrated approach to health promotion in the DHS? Kelly or Hilary, do you guys have any reflections on that question?
Yes, good afternoon, everybody. I think in my reflection, I would like to say that I think there's great alignment with what is in the framework and the journey that we've taken, noting that the document is a 2025 publication. So it's actually, it warms one's heart and in a way tell you that we're on the right track. I think we will definitely interrogate the WHO document more, as we work on our processes, because it's also a developmental journey for us. I don't know if Kelly wants to add.
Maybe I can also just jump in to say how we've really brought it to life with WOW, leveraging our WOW Champion Network, and really starting to have more robust conversations and tangible, practical solutions co-created with our champions across the life course approach, that being start well, live well, and age well. Thanks.
Nice. Thank you. Thank you so much. And just to further add, Nozipho and also Kelly, both your programs included a household and community champion model. What are the advantages of this? Yeah, could you just share a little bit?
Okay, I am trying to put my camera on, but speaking through Hilary's mic, so I hope you can see me okay. But the champions, as I've mentioned in my presentation, are really the spark plugs for change. And what we know from the behavior change nudge theory and so on is that in order for habits to be formed, for behavior to really be changed, it needs to be exemplified by communities, because that is one of the nudge principles, is that it must be easy to do. So community-driven activities like stretching, Zumba, the wellness clubs, beach cleanups, they are free and accessible, and they are community-driven. Another nudge principle is in terms of making it social. So WOW and the WOW champions, they really work within a group format. So it's about WOW champion groups gathering. They're using peer modeling, networking, and alternative social norms to reinforce these healthy choices. The champions are also provided with access to Cape Nature Reserves, as an example, partnering with other departments such as DCAS, really again to make it accessible, recognizing the diverse conditions that our communities live in. And then, of course, making a timely seasonal wellness messaging where champions are also able to mobilize within their communities. It's flu season now, so some flu prevention in winter, making it visible. So champions wearing the WOW brand with pride. I don't know if you can see my t-shirt, but I'm getting up quickly. So this is a real piece of gold. And then, of course, making it rewarding for our champions. So even without financial incentives, there is positive reinforcement. There's a sense of belonging that our community members really get from this program, and social validation as well as connection, which really supports behavior change and habit formation. Thanks.
Thanks, Kelly and Hilary. Zoleka, please can you go ahead and share? Just unmute yourself, please. Carissa, if you can, please can you unmute Zoleka?
Oh, thank you,
Oh, there
Nolu.
you go.
I've been able to unmute myself. I'm not familiar with Zoom, hence I'm struggling. But anyway, my colleague or someone in the audience assisted me. I was just looking at the chat box. There are questions that are asked today, and some of them are directed to me, and I wouldn't like us, when we depart from this platform, to leave the questions hanging. For instance, there is a question about the shortage of health promotion practitioners, or the limited number of health promotion practitioners. If you remember, when I was doing an introduction, I said the total number of health promotion practitioners in the Eastern Cape is only 69, and they are servicing a population of 7.2 million. And if you look at the Eastern Cape has about 705 wards. And therefore, that means that really we have a limited number of health promotion practitioners. However, this question is very crucial, because If you look at the nature of districts with the primary healthcare approach, we need more health promotion practitioners. We need to ensure that we build partnerships within the communities. If you look at the time during the COVID-19, the community members and the community leaderships assisted the Department of Health by providing us with capacity. We were given a human resource at capacity at community level. There were volunteers that came to assist health promotion so that we mitigate the COVID. And it wasn't easy for us. And this is still the case in the Eastern Cape. We have a limited number of health promotion practitioners, and not only the health promotion practitioners, including the resources and the tools of trade that they need so that they go to our communities. And for us to build sustainable relations within our communities, we need to be resourced as health promotion. And therefore, with your question that is asking, how do we work with and through the other health workers?
Sorry, Zoleka, please go ahead.
Oh, thank you. What I'm trying to say is, for us to work well in our communities, we build partnerships. We believe that we cannot do anything in our communities without our communities. We cannot do anything in our communities without the support of the community leaders. We believe that the community settings are a breakthrough for health promotion, because if we want to understand the community, we need to be in partnership with them. We can't do things for them. We need to do things with them. And therefore, we partner with other stakeholders that are outside there. But before doing that, we firstly partner with the stakeholders that are program managers within our department. And therefore, you find that some will provide us with the tools of trade that we are talking about, and others will provide the support through supporting us with other material that we need, the IEC material, and the rest. But the most important thing is that it's not easy to do health promotion work at community level without resources. Thank you.
Thank you, Zoleka. You raised some really important points. And I think linked to some of your reflections, I'm also keen to know from our three panelists, how do you engagement and sustaining engagement is always an issue. So some of the people in the chat are asking, how do you sustain that engagement? How do you keep it going, keeping the community sort of active and also, yeah, just managing that interaction in a sustainable way. Can you please have maybe Hilary or Kelly and then Zoleka or Nozipho just sharing some reflections?
All right, so sustainability is definitely top of mind at this point in time as we scale up. Why? But keeping our communities motivated has been very important for us over the last while. And it is way more simple than we think. And so what we've been doing is just being visibly supportive of our wellness or WOW champions is critical. So we've established a WOW champion group on WhatsApp, for example, that is now a network of these 700 plus champions. They are starting to naturally form a peer network as well and keep each other motivated. So this group is eating all my data, needless to say, but the group is so active and it's just so inspiring to see how the champions are making means and they are being innovative with a little support from us as a provincial office, but they are sustaining these practices. They have embedded partnership networks within their communities, working with the PHC facilities. I see one of Helen's questions here as well, integrating some of the WOW initiatives within the facility, using the waiting areas as an example, as an opportunity for health promotion, amidst many other examples. And so our private-public partnerships also become critical for us because we're recognizing that our champions have needs as well in order to sustain their activities. And that's where our departmental and the whole of government approach is important, because DCAS, for example, that being the Department of Cultural Affairs and Sport, supports us with transport of our champions. They support us with recreation venues that they open in our communities that are often unsafe for our champions to do their physical activity outside. But DCAS provides us with a list of recreation centers that our champions can access at no cost, and they can continue with their wellness efforts. Cape Nature, as an example, another partnership that is quite so new, but provides our champions with access to the nature reserves at no cost. And that in itself is also a big milestone for us to celebrate, because despite the circumstances that our champions often find themselves in, especially with safety issues, these partnerships help us provide a vehicle for our champions to continue and sustain their wellness efforts within the community. And then maybe just one initiative or innovative thing that I'd like to share, how our champions have really gone over and above. Who needs weights or dumbbells, right? Because our champions also don't necessarily have the financial resources to sustain some of these activities. But if you didn't know this, today you can make yourself a dumbbell with sand and a water bottle. And those are just among some of the innovations that our champions have come up with. And a certificate means so much to them. We've done name badges that our champions wear with pride, and those are among the things that keep them motivated, never mind the impact that they are seeing and having in their communities. Thanks.
Nice. Thanks, Kelly. I love that. Zoleka and Nozipho, is there anything you'd like to add?
Oh, yes. I just want to talk there about the supportive environment. If you listen to, I would just want to say they are the people who are wise, people like Angela, people like our Tatu Mandela. When we want to create a safe environment, we firstly need to provide knowledge, skill, and information, because we believe that knowledge is power. When people know, they always do what they know. But when people do not know, what is it that you can expect from them? I will always refer to the COVID-19 sketch. When you look at the COVID-19, people were doing whatever they wanted to do. But when people started dying, people were eager to listen. What are the messages that we are saying about prevention? And what we have learned from the COVID-19 scourge is that education was the best skill, because with the knowledge and information that they got from the people who were providing messages, including the champions like health promotion, people started to listen. And again, they did not only do that, they followed what was told to them. We wanted them to change their behavior, and they did that. And the introduction of the vaccine, we've seen people. We lessened the deaths, we lessened the illness, hospitalization, and that means knowledge is power. And in addition to that, we build relations with the communities. I will make an example of Nelson Mandela, where you see a health promoting churches forum. There you will find that there are more than 200 members from diverse sectors who came together so that they bring change to the lives of the people of South Africa. And we have seen the leaders from our church fraternity leading in changing the lives of the people. You'll find that they have capacity sharing, capacity sessions where people get empowered with information and skills, even though they have limited resources, but they share resources because they come from different backgrounds. And if you look at the Eastern Cape, we've managed to work towards achieving 15 health promoting schools which are fully fledged. I'm talking about the community settings, fully fledged and ready to be launched. And again, if you look at the community of the Eastern Cape, we've been able to engage with the key leaders, with the queens, with the kings of the Eastern Cape, and now our palaces are open for us to provide health services in them. And again, we have an example of a CCMDD that is a pickup point that is in Bazia, in Mthatha, that is functional. And it's been years since it's been functional and is decanting the chronically ill. And therefore, people now do not have to spend money for transport or travel long distances that are dangerous and what that pose a threat to their lives. I mean to say, if we can be assisted by the department, let the department strengthen health promotion so that we change the lives of the people. Thank you.
Thank you. Thank you so much, Zoleka. I really do appreciate that. And all the speakers in this first segment, I really like how these stories really show what can work with real world examples, because sometimes people can get overwhelmed with strategies and think, oh no, how do we even begin to implement that? And we've really heard some really good examples and innovations using our bodies as dumbbells. So there's really a lot to think about. And before I hand over to Eleanor, just to unpack how we can shift entire systems so that these interventions can thrive everywhere. Please do go and also put in your answers and responses on the poll that we showed earlier. We'll be reflecting on that a bit later on. So Eleanor, over to you to explore the strategic side of reorientation. Thank you, everyone.
Thanks so much, Nana, all the colleagues for their engagement so far. So a reminder about the poll. Maybe Carissa or Leila, if you could repost the link and the question in the chat for people who joined more recently. But please do, colleagues, keep engaging in the chat and complete the poll when you have a second. So having spoken a little bit about the kinds of interventions that can enable health promotion and wellness, what we want to do now is turn our attention to the kinds of policies and strategies that enable a wellness and health promotion oriented health system. So recognizing that given that our health systems are often by default curative and programmatic in nature, there's a challenge with regards to reorienting the health system towards health promotion, and this is a strategic challenge. And so we have two speakers to share their experience in this regard. And I'd like to introduce the first, who is Dr. Hilary Goeiman, who we've heard from a little bit, but she's going to give us a presentation now. Hilary, over to you.
Good afternoon, colleagues. I will be sharing our experience moving from a vertical health program focus to a life course approach with an emphasis on the link to health promotion and wellness. I'll share how we moved from fragmented vertical health programs to a more integrated life course approach, and how this shift enables us to place wellness and health promotion at the center of care. We can go to the next slide. I'll cover a quick background where we started and why change was needed, the key principles guiding our reorganization, the role and function of the Service Priorities Coordination Directorate, and then some challenges and lessons that we've learned and we continue to learn, and importantly also share some opportunities as we see to advance health promotion and wellness through this new approach. We can go to the next slide. So where have we come from and where are we heading? So historically, as most of you know, and I think still in existence in many areas, our health system have organized vertical programs within our case, separate directorates that we had prior to 2021. Separate community-based services, facility-based services, as well as HIV/AIDS, STI, and TB as a directorate. And we also have seen during this period that these programs have allowed us to achieve disease-specific targets, but often led to silos, duplication, and a fragmented experience for our clients. So clearly, we have noted over this time that this didn't adequately support wellness, which then requires us, with wellness to look at the whole person and also require us to look at the wider determinants of health. And I think ultimately also, continue working in this fashion also did not necessarily empower the clients that we serve and the population at large to take control of their own health. So our MEEP and post-COVID recovery gave us the opportunity to reorganize the system that integrates services, focuses on the patient journey through the life course, and places health promotion and wellness at the heart of care. Can go to the next slide. So our reorganization was guided by several principles embedded in our strategies, as you can note in the middle of the slide, which all directly speak to health promotion and wellness, the aspects of person-centered care, the fact that the focus on wellness is not just disease management, continuity of care, alignment with community-oriented primary care, which connects the health services to community. And then it was also important for us to recognize these shifts that I've explained that's needed. Living the values of the organization, while at the same time we need to ensure good governance with clearly defined roles and responsibilities and decision-making capabilities, recognizing the diversity and the capacities that's needed on the platform. I think if Dr. Beth Engelbrecht is in the audience, I think while she was the HOD, this was specifically also highlighted, and we've been working on it to not only focus on the technical capacity, but also the relational capacity and leadership, ultimately working together as a whole system with the whole of society. So the Service Priority Coordination Directorate was born, giving really we can go to the next slide, giving us or make the vision a reality. So we've moved away from the vertical programs that we have had in the past to life course units, and you will see the main areas of work. And within all these units, working together to promote wellness across the life course. So we have an early life course unit, late life course unit, disease outbreak and communicable disease control, increasing wellness. So that is the unit that Kelly specifically is working in. And, integrating projects like the Western Cape on wellness, community mobilization, and workforce and workplace health programs, as well as a clinical policy and governance unit, and then having a provincial support unit that bring together the coordination of donor relations, working with external funders, NPOs, and then while at the same time not formal units integrating other projects into the space that add value to the work that we do. For example, the scaling use of data, decentralized approach. We can go to the next slide. So in terms of our role, we are the interface with the National Department of Health. Key for us is ensuring that we make sense of, what comes into the system, how it lands on the system and in the system to prevent duplication, policy development, adaptation, translation, engaging in decision-making platforms and ensure that there's accountability, stakeholder engagement, to make sure that the diverse inputs are incorporated with what we do, while at the same time we mitigate risks. And I've just put a few examples of some of the work that we are engaged with, outbreak response, where we then integrate all this that I've just mentioned. The COVID vaccination is another good example. And more recently, managing the US aid funding withdrawal and the impact, as well as the mitigation plans on the system as a collective. So then how do we do it? We always get stuck with a question, how? We do it through connecting, collaborating, and co-creating with our stakeholders, coordinating at a central level, but working very closely across and in the entire system. But key is for us to ensure that there's a balance, considering the context, the service need, the responsiveness, outcomes, and impact while we mitigate risks. So what were some of the challenges and learning for us up until now? We can go to the next slide. I can clearly say that this transition has not been easy. We faced resistance from staff who was accustomed to old ways of working, structural misalignment, fragmented systems, gaps in training. But of course, these challenges reinforce some important lessons and learnings for us, as well as to then collectively come up with how we mitigate these risks. So especially through leadership, trust, and clear communication, absolutely essential components, and moving to a state where health promotion is everybody's or everyone's responsibility, while at the same time we have a good understanding of the community context, because that is critical. Then moving on to the last slide in the segment is just to end off with some opportunities that we have moving away from vertical approaches to a more life course approach. And I think there's definitely, in the context of advancing health promotion and wellness, a myriad of opportunities, building stronger teams that are committed to empowering people and communities to improve their own health, aligning policy structures, infrastructure to support integrated patient-centered care, making it easier for people to access preventative services, redesigning our systems, for example, appointment processes and patient flows, to prioritize prevention and health education, and then just strengthening staff capacity and enhancing collaboration, both at national, provincial, district, frontline, community, and all levels. And in essence, moving the conversation and the system from illness to wellness. Thank you very much.
Thank you so much, Hilary. That was so insightful and interesting and exactly spot on time. So well done for that. So next I'm going to hand over to Mr. Jabulani Mndebele, who is the Chief Director for District Health Services for the KwaZulu-Natal Department of Health. Mr. Mndebele, thank you so much for joining us, and over to you. And please remember to tell us when to move on your slides.
Thank you, Eleanor, and afternoon, colleagues. I'm going to share with you the process that we have undertaken for KwaZulu-Natal to create a KZN integrated multi-stakeholder health promotion and well-being strategy. Next slide. So let me first indicate that health promotion is everybody's business. And I must indicate that health promotion is not really appealing to most of health workers. So it's not something that they are easy to buy into. So what is this strategy aiming to achieve? Or why did we develop this strategy? The aim of this strategy is to actually create a self-sustained community, a community which can rely on themselves, not on the health system. And the reason why we call it integrated multi-stakeholder, because we didn't want this health promotion to be a Department of Health thing. We wanted it to be the government of KwaZulu-Natal health promotion strategy. What were the influencing factors that, next slide, that made us to actually develop this strategy? We were looking at the trend of the shrinking budget because the province for the past 5 years, instead of getting more budget, the budget is going down. So we needed to actually put health promotion in front so that we can be strong on preventive and promotive. And we're also looking at the issue of the introduction of an NHI, because NHI can only survive where there is a strong health promotion activities. If you don't have that, NHI won't survive. And the other two factors were that the rural nature of our province and also dealing with this, the social determinant for health. We also were targeting certain areas, 5 areas that we're looking at to actually achieve through this strategy. One was the issue of a reduction in teenage pregnancy. Second one, gender-based violence. Third one, eliminate severe acute malnutrition. The other one, TB, HIV, and chronic disease management. And then looking at the process itself that we undergone, it's firstly, we had to lobby for this strategy. So we targeted ESCO and MANCO to actually to get a buy-in from. That means internal. And then from externally, and then we targeted the Office of the Premier as a coordinating body within government. And then we also identified various stakeholders, of which you can see on the presentation, the stakeholders that we identified and we pull into this strategy. Next slide. And then after that, with this, then we formulated a task team or a working group So all the people who had interest, all the people that were listed in the previous PowerPoint presentation were the core team that was driving the whole strategy. But we further subdivided the task team into sub-task team because we had 5 goals that we're looking at in terms of the strategy. And then we also, next slide, we also had a writing team and the team that was communicating. So those were the task team. And then further than that, then the next process that we followed, next slide, was to actually conducting road shows. The reason why we conducted road shows in all our 11 districts, and those road shows were not targeting Department of Health staff. They were targeting all field workers in government, including civil society, NGO, and the rest, so that we can also get a buy-in from them. At the district level, we look at the issue of identifying champions who can drive the process. And we didn't want to come up with new structures. We build on the current existing structures, your DAC, your DT team, and any civil society structures that we influence at a ward-based level, those that will assist in actually driving the strategy. I must say all the members of drawing this strategy were appointed formally in writing. And then next slide. And then we also progress in terms of the first area that we wanted to also tackle was to map everything that is happening in the world. What are the resources, not health resources? If there's a group that deals with gender-based violence in that world, we map it. And in this map, we had an objective because we wanted the community to actually view, to use this mapping to view where they can access services closer to them in the world. The other part was for all the government departments to feed in information like your teenage pregnancy stat at a ward-based level so that the councillors and any community can be able to view where there are burden of diseases. Next slide. And then there are critical success factors that we learn through this process. Number one, when we developed the strategy, we needed to have a clear goal and definition. We needed to also be able to identify our stakeholders that can add value in promoting the integrated health promotion strategy. We also lobbied for high-level support. You know, if you get the office of the premier, you get your ESCO, you go and present the strategy in cabinet, then you actually lobby that support so that we can have a buy-in. And also the issue of multi-level stakeholder engagement, that we needed to make sure that we leave no one not knowing, not contributing to this strategy. And also the issue of road shows where we're doing a public mobilization and also getting the buy-in so that even at a ward level, people should understand that there's this integrated health promotion strategy. And then the formation of a dedicated task team, because it's to drive a strategy where they are multi-sectoral, where you have got civil society, where we have got NGOs, where you have got academics. It's not as easy as ABC. So you actually needed to get dedicated people who can continue to push the strategy. Uh, I think those are the key. The last slide, those are the actually key success critical factors that one can share with you. I see Eleanor is already saying the time is up. So thank you, colleagues. That's what we wanted to share as KZN Health.
Thank you so much, Mr. Mndebele. That was really, really interesting. And I think, yeah, it's so great to get a perspective from a sort of policy and strategy viewpoint on how you go about the process of creating an enabling health system, a system that enables a wellness focus. So what we have now is some time for questions and participation from the audience. I have some questions. I'm sure there's been a lot of engagement in the chat, but I'll pause for a moment and see if there's any immediate hands. Nokulunga, go ahead.
Thank you so much. It's not so much of a question as just a comment. I think I'm extremely excited to be here, and I'm extremely excited to hear every activity, that has been discussed. I once worked in KZN with HST in the Unfinished Business Project. And I think I was very excited when I came to this webinar because I kind of expected that some of the lessons learned from the Unfinished Business Project would be shared here, because that was one project that harnessed all existing structures from the public health sector, from the community, multi-sectoral approach, approaching other departments as well, partnering with the private sector and so forth. And I'm mentioning that in particular because I feel like every year, there is funding that is handed out for all these strategies so that we learn these lessons. But what is most key for me is, are we documenting, or how are we tracking impact? And are we documenting it not just so that we can report to say we used the money correctly, but to say what was most impactful, and this is why we are scaling. And that's what I think I'm a quality improvement person at heart, and that's the element that I find is missing. We can do all these activities and go all these routes, but when we are not coming back to say this is what worked the most because these are the indicators we were tracking, or this was the impact, and as a result we are scaling. For example, the Unfinished Business Project was targeting case detection for HIV, TB, and malnutrition in 0 to 19 years old. And simply by sensitizing nutritional screening, we increased the index of suspicion for HIV and for TB in clinicians at primary health clinics. These are the kind of lessons that should be highlighted so that we can actually make means to scale them up, especially because NHI is coming and primary healthcare is the entry point. Thank you.
Thank you, Nokulunga. I think that's a really interesting and insightful comment. I think I was going to ask a question kind of related, which was, I think many of the speakers have mentioned the sort of monitoring and evaluation component, and some of the speakers have mentioned supervision and accountability. And I can imagine that there are different kinds of challenges with monitoring and evaluation and with accountability when you're doing out of facility services, when you're doing close to community services. But then the question beyond accountability and monitoring is, how do you learn? How do you make sure that you know what's working and what's not, and take those lessons and scale them up somewhere else. So I think you've asked such an interesting question that it's worth pausing there and seeing if Hilary or Jabulani want to respond quickly.
So maybe I can respond to the question that Lucy put in the chat in terms of what our experiences in terms of tackling the more curative mindsets that are embedded in our healthcare system. Definitely not easy. I think for me, being persistent with the key message in terms of the importance of us moving from illness to wellness is important. Then definitely presenting the evidence. Also sometimes people that work in finance, they want to see the financial impact of not investing in wellness. That helps, and then showcasing some of the success stories. Also, in my experience with how we are doing our interventions now, it's to bring forth the wellness or the prevention interventions as part of curative programs. So if we talk about HIV and TB, there are many preventative aspects that we need to highlight before addressing the burden. So building that in as part of the response strategy, for me, I think that has also shown some positive effect. And I think advocacy, both internal and external, we also require that to start to tackle the curative mindsets in the system.
Thanks so much, Hilary. Just in the interest of time and noting that there's two other hands up, I'm going to ask Tamba and then Marsha to ask your questions, and then I'll come back to Jabulani and then Hilary to pick up on whichever threads you feel like expanding on a little bit more. Tamba, go ahead.
Good afternoon, colleagues. Thank you very much for the opportunity. I'm Tamba Nobatana from the Department of Basic Education. I just want to check if the colleague from the KZN, the last presenter, if is able to share with you coordinators of this webinar, that strategy, the document, that of the full document that was talking about, and then can be later shared with us, if that is fine with them. Thank you.
Thank you, Tamba. Jabulani, I'm going to give you a chance to respond, but let's just take Marsha's question first.
Thank you, Eleanor, and thank you, colleagues, for the wonderful presentations. I have a question about stakeholder involvement in promotion, health promotion and prevention. So we know that at a community level, there are factors that drive unhealthy or health-harming behaviors. So, for example, the illegal trade of alcohol, selling alcohol to minors, sugary products being sold in various places to children, for example. I wanted to ask the colleagues, given this is not the explicit mandate of health to monitor, for example, alcohol outlets, how hard or what are the opportune moments? What does it take at a community level to engage these kind of sectors to create a healthy environment, which obviously supports prevention, health prevention and promotion? And I realize this is a very complex task, but I was just wondering if there are reflections on how easy or hard to do this is from a point of view of health. Thank you.
Thanks, Marsha. Great question. And I think when we were chatting to Nozipho, she also mentioned some of the challenges of getting other stakeholders to take ownership of the issue and to take ownership of the program. So, Mr. Mndebele, over to you, and feel free to answer from the various questions that have been posed.
So maybe let me start with the one for the strategy, to share the strategy. I think for for salad, we can share it to salad, and salad can see how they further share it, because it's an open document. It includes various stakeholders. And then to the second question, you see, we have got a tendency when we go to the community to go and tell them, these are your problems. The lot of liquor places in these areas are a problem. So the approach that we are undertaking is that as we go to the ward, although we have identified teenage pregnancy, all these issues that we are talking about, but at the ward level, they reprioritize. If the community say, okay, we really see this is as a problem, then they prioritize it. And by doing that, it's easy when you mobilize the community to actually deal with the issues themselves. If there's issue of illegal drugs and whatnot, you don't come from outside and say, this is what I see. You actually engage them, and then they prioritize, they rank the issues, and then they will need to come up with the strategy. And then for you is to empower and support them so that they can go around whatever issues that they're experiencing. Thank you.
Thanks so much, Mr. Mndebele. I think I really liked your point, and it was something that came through in the first panel on interventions as well, is just the value of recognizing the tacit knowledge of community members, of community champions, recognizing that communities know what their most pressing challenges are. And so if your intervention is responsive to that challenge, there will be buy-in, but you can't come in saying this is what your pressing challenge is. Hilary, do you want to offer any reflections there on any of the conversations since you last got a chance to speak?
Yes, I actually asked Kelly to just share some of her experiences with one of the questions in the chat around using nudge strategies to improve how healthcare providers implement policies and practices.
No, thanks, Hilary. And maybe also just to cover, I think it's Marsha as well that was speaking about the sugar tax and just really creating those enabling environments for our communities as well, which is an important enabler for us to actually see and realize well-being societies. A utopia, it may seem at this moment in time, but I'm sure we will certainly get there. So I think the first thing is really to look at policy advocacy, advocating for healthy public policies to achieve health outcomes, to strengthen these wellness enabling environments. And perhaps that goes beyond us in this very room. So how do we start leveraging the legislative landscape and the policy environment at the highest level to influence these changes that we like to see? I'm starting to notice that some of the big franchises, you pay less for sugar-free Coke, as an example. What happens to that sugar tax? Can we use that to really strengthen our health promotion interventions? And then how can we use those kinds of funds, among others, to also help us realize this sort of behavior change, nudge theory, using behavioral economics as well. So, I mean, as we know, a nudge is a way to subtly influence people's choices, to encourage them to make decisions. And so we are in the department already thinking about what does a public sector rewards program look like? How do we sustain that, importantly, because we recognize that by issuing perhaps food vouchers or anything that is a dependable may not always be sustainable. But what can we do within the system to cover the healthcare worker to also make the shift, but also our communities to form the habits to want to live a healthy life? What does that look like for us? And so those conversations are are quite interesting at the moment, because as we also know, that through nudge theory, it is about encouraging healthier decisions that are beneficial for the people, without restricting freedom or changing the economic incentives. And so it is a technique we know that leverages cognitive biases and heuristics to guide behavior in a desired direction. And so we really hope that through our work and our collective efforts, we can co-create something, not discovery vitality per se, but discovery has shown us how they've got it right to really see a return on investment at the end of the day. So yeah, looking forward to seeing how that all shapes up.
Thanks, Kelly. Yeah, really interesting. And I think, yeah, learning the lessons of what other sectors are doing is an important thing to do. Zoleka, we're tight on time, but I'm going to give you the last word of this segment before we move on to the poll responses. Go ahead.
Thank you so much, Elena. I was touched by the statement that was made by the GM when talking about the societal issues, which include teenage pregnancy, closing of the access of the children to the taverns. I just want to say the Department of Trade and Industry has they have their own national policy that talks to the issue of alcohol to the minors, and also issuing of licenses to the tavern owners. And if we look at the issue of implementing the policy, we as the citizens of South Africa have a responsibility. But above all, I want to challenge the audience into saying, if we want to reduce the burden of diseases, reduce morbidity and mortality, we need to strengthen health promotion. And again, for us to ensure that we are not doing things for the community. Remember, the community is organized. We have the civil society in our communities. We need to ensure that we empower the community. We integrate our policies so that we are able to be of usefulness to the communities. And again, we need to ensure that we use a holistic approach. You cannot treat a person physically and forget about the person mentally, forget about the social wellness of the person. And therefore, I was thinking that when I was still at school, when it was said that there will be health for all by the year 2000, I was thinking that these days we wouldn't be talking about the burden of diseases in our areas, but we would be embracing the impact of health promotion as a program in our country. And not only that, we would be ensuring that even though it is difficult to measure behavior change and it is taking time, but we would be seeing the fruits of the behavior change in our society. And therefore,
Zoleka, I'm so sorry. I'm going to have to interrupt you, but I interrupted you right then because I think you've done exactly what I was going to do next, which is sum up the conversation. And I especially liked what you were saying about, there is an increasing recognition that health is everybody's business, and there is more intersectoral willingness now to engage and to be a part of the solution. And I'm so sorry to have interrupted you. I'm just aware that we're running out of time. So colleagues, at the beginning of this discussion, we asked you to answer a poll question, which was, what one thing do you think could unlock the potential of the district health system to better support health promotion and wellness? And I'm going to hand over to Leila now to just give a little summary of the responses that we got in. Leila, over to you.
Good afternoon, everyone. So if you'll just allow me a moment to share my screen. So firstly, Eleanor, you can just indicate if you can hear me, if you can see me, and if you can see my screen.
I'm doing well. Thank you, Leila.
Okay, fantastic. Thank you. So, firstly, thank you for interacting on the poll. We did receive quite a number of responses, and I have to say that there were quite a number of responses related to community participation and community involvement. And I think from the comments and the questions and the discussion, that was definitely evident. So I'm going to just take you, I've tried to summarize it with my good friend ChatGPT. I've tried to summarize the responses into 6 key themes. I'm going to take you, for the sake of time, just take you through the 6 themes. So as you would have also heard through the conversations, leadership, governance, and then political will is necessary for us to incorporate, to embed wellness and health promotion into our DHS strategies. And then there was a big theme around the workforce development and really including our workforce, upskilling the workforce and ensuring that they are able to practice at various levels within the primary healthcare services. And then, like I said earlier, community involvement. That was quite a big one. Empowerment of communities, involving communities, having communities be part of the decision-making processes, and how requesting them to assist us in designing the interventions and the activities specifically related to communities, but also having them assist us in tracking the yields within their specific communities. The 4th theme was really around, I think, the way the service is designed. We should focus on an integrated, preventative, and person-centered care approach, looking at proactive and preventative care and having a core mission related to this. We should realign our education, our awareness, our policies, and it should really be a mindset change that we embark on. We also have to identify and address the social determinants of health. And as we all know, and I think it has been said several times during the session, this is not something we can do as health in isolation. Which leads me to the next key theme, which is around integration or at least intersectoral collaboration and partnerships with other sectors, NGOs, community structures to really ensure that we do this as a collective. And then the last theme was really around data, communication, and technology and how we use real-time data to inform the decisions that we make in specific communities, also to ensure that it relates to that specific community's health needs and wellness outcomes. And that's all from my side. Thank you very much, Eleanor.
Thank you so much, Leila. You did amazingly well to synthesize all of those inputs in such a brief amount of time. Colleagues, this has been a really engaged and participatory session, and just a huge thank you to everyone, especially the speakers, but the participants as well, just for so many questions and so much discussion in the chat. There was really, sometimes we worry that there's not going to be enough audience participation, and that was definitely not a challenge with this webinar. So thank you for that. I would like to say that we will make sure that the information that's come through in the chat, all of the comments and all of the questions are reflected in the webinar summary, which we will put out. And of course, we will make the link to the video available to everybody so that you can share that within your networks or come back to it if you feel like you want to. And I think with that, all that's left for me to do is to thank everyone for their time, especially our speakers who gave so generously and who were so willing when we contacted them to just say, yes, sure, I'm happy to share my experiences, including Zoleka Mbange, Kelly Fortune, Nozipho Madi, Hilary Goeiman, Jabulani Mndebele. A huge thank you to all of you. And a very big thank you to the Salad Webinar Working Group for all the work that you guys put in bringing this together. It takes a lot to pull a webinar off, and I think this one went really well. And as usual, we will make the link available, and we will share the all the inputs and any other materials that people have asked for in the chat. We will make sure that that's made available to you through the SALID network and on the mailing list. And if you're not on the mailing list, but you managed to get on the meeting, the email address to contact is kgovender@uwc.ac.za, which is on the screen. So please do get on there, and yeah, then you can be engaged as we move forward. So thank you very much again, and yeah, well done to all the speakers.
Thank you, Eleanor. Bye, everyone.
Thank you too.
Thank you.
Fantastic, and goodbye, everybody.
Bye, everybody.
Thank you.
Bye.
Thank you, colleagues. Bye-bye. Excellent.
Thank you. Bye.
Bye, everybody. So exciting. Thank you. Bye.
Mm.